Welcome to the Funnel Effect. Today we are undertaking a deep dive into, one of the most complex and frankly rapidly evolving areas of modern cardiology. We're talking about non-ST segment elevation acute coronary syndrome. Our source material for this essential discussion comes from a really recent state-of-the-art review. It was published in Eurointervention in December 2025. The title is Diagnosis, Risk Stratification, and Early Management of Non-ST Segment Elevation Acute Coronary Syndrome. And that comprehensive review was authored by Mila Kovacevic, Daniel A. Jones, Holger Thiel, P. Gabriel Steg, and Vijay Kunadian.
It's a fantastic piece of evidence to work from. And for our deep dive today, we're going to be focusing pretty heavily on non-ST segment elevation myocardial infarction, or NSTEMI, as you'll hear us call it. That's the more serious, life-threatening subset of NST-ACS. The NST-ACS umbrella, it also includes unstable angina, or UA.
Right. And our mission really is to synthesize the current evidence-based roadmap for managing NSTEMI. This condition requires these intensely customized approaches, especially when you compare it to the more standard, streamlined protocols we have for its more dramatic cousin STEMI.
Exactly. And STEMI is the trickier sibling, no question. And the sheer scale of the problem demands this kind of detailed review. I mean, cardiovascular diseases, CVDs, are the #1 cause of death in Europe. And when we narrow that down to ischemic heart disease, IHD, it's responsible for a staggering 38% of all CVD-related deaths in females and 44% in males.
That's a huge burden. We're talking about millions of people. The sources cite that in 2019 alone, countries within the European Society of Cardiology, the ESC, saw 5.8 million new cases attributed to IHD. So this is not a niche problem. This is a global health crisis demanding the most efficient and precise management strategies we can possibly muster.
And the challenge you see lies in the nature of NSTEMI itself. When a patient presents with a classic heart attack, a STEMI, they have that persistent ST segment elevation on their ECG, which typically signals a complete critical blockage of a major coronary artery. It demands immediate, clear action.
Get him to the cath lab now.
Right. NSTEMI, by contrast, is characterized by myocardial necrosis heart cell death, but without that persistent ST segment elevation.
So we have the cell death, the damage is happening, but the electrical signal on the ECG isn't screaming red alert in the same way.
Precisely. It often reflects an incomplete or maybe a transient coronary artery occlusion. And that variability, the incomplete blockage, the potentially transient symptoms, that's exactly why the management becomes so complex. The underlying mechanisms can be highly varied. You might have the classic plaque rupture, but you could also have plaque erosion or entirely different causes like coronary microvascular dysfunction.
So it's a whole spectrum, not a single clear pathology. But despite this variability, the stakes are just as high. NSTEMI still carries a substantial prognostic risk. We're talking a significant chance of subsequent heart failure, debilitating long-term events, and, of course, death.
And that need for precise, rapid risk stratification is the absolute mandate. The moment a patient arrives, the clinical team needs to figure out who they have in front of them, what is happening inside their chest, and how fast they need to act. This brings us directly into the diagnostic cornerstones that shape that immediate management.
Okay, let's unpack this clinical workflow. When a patient arrives with chest pain or other symptoms suggestive of acute coronary syndrome, the very first step, the starting gun, is the 12-lead electrocardiogram, the ECG, right at the first medical contact, the FMC.
Correct. The ECG is cheap, non-invasive, and it's fast. In NST-ACS, we are looking for symptoms of myocardial ischemia combined with specific characteristic ECG changes. The classic indicators that suggest NST-ACS, the things that distinguish it from a normal ECG, are horizontal or downsloping ST segment depression.
And what about the T waves? Are there clues there as well?
Oh, absolutely. You might see T-wave changes, things like deeply inverted T waves, or even biphasic T waves, where the T wave starts positive and then flips negative. Critically, these changes may be dynamic. They can come and go. This reflects, a subtotal occlusion that opens and closes, or maybe a transient vasospasm. This dynamic nature is a major warning sign.
And we really have to stress the importance of recognizing what are called these STEMI equivalents. These are patterns that may not technically meet the criteria for a massive ST elevation MI, but functionally, they signal the same immediate catastrophic emergency, the kind that requires the patient to be in the cath lab within 2 hours.
These are vital clinical nuances. The two most important examples are Wellens syndrome and De Winter T waves. Wellens' syndrome is characterized by these deeply inverted or biphasic T waves, specifically in the precordial leads V2 through V4. This is a very, very strong signal of critical proximal left anterior descending artery stenosis, the LAD. the widowmaker artery.
And De-Winter T waves.
Yeah.
How do they differ?
They look a little different, but they're equally ominous. They present as upsloping ST depression, coupled with these prominent symmetric T waves in the same precordial leads. Both of these patterns demand the same urgency as a full STEMI protocol because they indicate a near-total occlusion that is highly unstable.
It sounds like there's just immense pressure on that initial ECG read. But here is the major complexity the source material highlights.
Yeah.
We cannot rely on the ECG alone, because in over 1/3 of NSTE ACS patients, the initial ECG may be completely normal or non-diagnostic.
Which is a sobering thought. And it means we are immediately forced to rely on the second cornerstone, biomarkers. Specifically, the game-changing introduction of high-sensitivity cardiac troponin, or HSDCTN.
Let's spend some time on this because it truly has revolutionized the cardiology workflow. What does high sensitivity actually mean in practical terms for the clinician?
It means the assay can detect incredibly minute changes in troponin concentration. Troponin being the protein that's released when heart muscle cells die. It can detect it much sooner and at much lower concentrations than older assays ever could. And a dynamic elevation of this protein above the 99th percentile of a healthy reference population is the definition of a myocardial infarction.
So it gives us a much earlier warning. How does this translate clinically at the bedside?
It means enhanced diagnostic sensitivity, especially if the patient presents very early, say within the first hour of chest pain. This efficiency is paramount because it allows us to rapidly apply rule-in or rule-out protocols for MI. The ability to quickly and safely rule out an MI dramatically reduces unnecessary hospital admissions, frees up beds, and lets us focus resources on the true high-risk cases.
And the specific algorithms used exploit this rapid detection. We're talking about things like the 0-hour, 1-hour algorithm.
That is the preferred approach, yes. With the 0-hour, 2-hour protocol being the second option, the power of these rapid protocols lies in their negative predictive value, or NPV. It exceeds 99%. So a negative result means the probability of a myocardial infarction is extremely low. This allows for safe, early discharge or moving on to other non-invasive testing for low-risk patients. Conversely, their positive predictive value, the PPV, is around 70 to 75% for ruling in cases that absolutely need an invasive evaluation. That level of certainty in under 2 hours is transformative.
The efficiency is undeniable. And speaking of speed, the sources discussed take this technology out of the central lab and moving it right to the patient. Point of care, or POC, HSCTN tests in the pre-hospital setting.
This is the newest frontier. The Arctica trial, which is cited in the review, demonstrated the feasibility and safety of using these POC troponin tests in the pre-hospital environment. In the ambulance, these tests were used to identify and rule out NSTE-ACS in low-risk patients, and the trial confirmed this strategy was both cost-effective and safe, with very low one-year rates of MACE major adverse cardiovascular events.
So a paramedic could potentially use this information to make faster, better decisions about transport and triage.
Exactly. These POC tests integrate perfectly with existing risk stratification tools, like a modified heart score. That's history, ECG, age, risk factors, troponin. By combining the clinical assessment with the rapid POC troponin result, paramedics can stratify patients before transport. This influences whether they go to a primary PCI-capable center or a local non-PCI hospital. It optimizes resource allocation right from the very start.
Okay, so once we have the ECG findings and the initial troponin results, we move to the objective part of the process, risk stratification tools.
Yeah.
The two giants here are the GRACE score and the TI score. Why are these scoring systems so important?
They are critical because they standardize the assessment. They objectively evaluate the risk of future adverse outcomes, death, MI, stroke, and this allows clinicians to tailor the intervention strategy. However, the source material notes a persistent issue. These tools, despite their validated usefulness, are often underutilized in practice.
And that underutilization leads to this concerning finding of risk treatment misalignment.
It does. This misalignment means that sometimes the higher risk patients are paradoxically referred less frequently or later for definitive invasive care. The reasons are complex. They might be older, have more comorbidities, or the clinician perceives a higher procedural risk. But the result is that the math gets ignored, potentially compromising patient outcome. We really need to make these scores a non-negotiable part of the clinical decision-making process.
Let's break down the more complex tool first, the GRACE score, the Global Registry of Acute Coronary Events.
GRACE is the gold standard for predicting in-hospital and long-term mortality risk. It's a comprehensive tool based on 8 key variables, and its point structure reveals a lot about what truly drives risk.
Give us an example of how the points are structured. How does it weight things?
Well, age is the single most heavily weighted factor. A patient who is 30 years old gets 0 points, but a patient 90 years or older gets 100 points. That immediately tells you that chronologic age is a massive predictor of outcome in ACS. Other variables include vital signs, heart rate, and systolic blood pressure, but also factors reflecting overall systemic status, like serum creatinine. That indicates kidney function, which is often compromised in cardiovascular disease.
And the clinical status of presentation. What about that?
We also score for a history of cardiac arrest at admission, the presence of ST segment deviation on the ECG, and whether the cardiac enzymes, the troponin, are abnormal. Finally, the KILLIP class, which measures the severity of acute heart failure, like pulmonary congestion, is a huge factor.
So you add up all the points. What does the final score tell you?
GRACE is continuous, but we tend to categorize it into 3 buckets for decision-making. Low risk is 108 points or less, which correlates to less than 1% in-hospital mortality. Intermediate risk is 109 to 140 points, so about 1% to 3% mortality. And the high-risk category, which is the most critical for management decisions, is anything over 140 points. This correlates to mortality exceeding 3%. This score is what dictates the timeline for intervention.
Now, compare that to the TMI score, the thrombolysis and myocardial infarction score. It seems much simpler, more like a quick checklist.
It is simpler, and it's designed to be rapid and categorical. It gives you a quick risk estimate for the short-term death, new MI, or severe recurrent ischemia within 14 days. It assigns 1 point each for 7 binary variables: age 65 or older, having 3 or more CAD risk factors, known CAD, prior aspirin use, 2 or more anginal events in the last 24 hours, ST segment deviation, and elevated cardiac biomarkers.
So a maximum of 7 points. Much more straightforward.
Correct. A low score, say 0 to 2, means a very low risk of an adverse event, less than 5% probability, while a high score, 6 or 7 points, indicates a probability over 40% of developing an adverse primary endpoint within 2 weeks. It's an excellent tool for rapid triage, but it definitely lacks the long-term prognostic power and comprehensive nuance of the GRACE score.
Right. So the crucial takeaway from this entire first section is that these scores, combined with the sensitive troponin assays and the ECG, fundamentally determine the patient's risk profile. And that risk profile is the primary driver of the next major decision: the timing of invasive intervention.
Precisely. Once we have stratified the patient, the fundamental clinical choice is between 2 strategies: a routine invasive approach or a more conservative selective invasive approach.
Let's start by defining what we mean by a routine invasive strategy.
This means every eligible patient, regardless of their immediate clinical stability, is scheduled for invasive coronary angiography, or IC. And if significant blockages are found, this is typically followed by revascularization, either PCI, which is stenting, or CABG, open heart surgery.
And the conservative strategy, what does that look like?
That approach is more cautious. Angiography is reserved only for patients who show refractory symptoms, chest pain that won't go away, or clear evidence of significant ischemia confirmed by non-invasive testing, like a stress test.
Historically, the evidence base for high-risk patients has strongly favored the routine invasive path. What were the landmark trials that really solidified this approach?
We're talking about trials like FRIS-2, RADA-3, and TACTICS-TIMI-18. These were landmark trials conducted in the late 90s and early 2000s. They confirmed that for high-risk NSTE ACS patients, a routine invasive strategy significantly reduced the composite endpoint of death or myocardial infarction compared to the selective conservative approach. This established the current standard of care.
But, and this is where the true depth of this source material comes in, when we dive into the long-term follow-up findings, the survival benefit seems to become more nuanced. It shifts the narrative just a little bit.
It absolutely does. The long-term data confirms the benefit is sustained, but we have a better understanding of the mechanism of that benefit. For instance, the RADA-3 trial at 5 years showed that the routine invasive strategy strongly reduced death or non-fatal MI, particularly for the highest-risk patients. The odds ratio was 0.44. However, when they followed those same patients out to 10 years, that early difference in all-cause mortality largely diminished. It wasn't there anymore.
So the survival curve flattened over a decade, but the overall strategy still offered a benefit. Where did that sustained advantage come from then?
The FRIS-2 trial, which followed patients for 15 years, provided the clearest answer. It demonstrated a sustained overall benefit of the invasive strategy, but this benefit was primarily driven by the postponement of new myocardial infarction and a reduction in recurrent ischemia. It wasn't necessarily a sustained, immediate reduction in all-cause mortality over the very long term.
I see. So the invasive approach doesn't necessarily make you live longer overall, but it significantly reduces the chance of you having another heart attack or needing another urgent procedure down the line.
That's the core realization. And we must remember the context of these trials. They were conducted before the routine use of modern tools like radial access for procedures, before second-generation drug-eluting stents, and before the potent antiplatelet agents we use today. A later comprehensive meta-analysis confirmed this. Yes, no significant long-term mortality difference around 10 years, but a consistent and extremely important reduction in ischemic events.
Okay, so assuming we've decided on the invasive route for a high-risk patient, the most crucial tactical decision is the timing of the invasive coronary angiography, the ICA. The guidelines are very specific here.
They are. We categorize the timing based on the immediate threat to the patient. The fastest track is immediate ICA. That means within 2 hours of admission. This is reserved for very high-risk patients, and it's a Class I recommendation, meaning it must be done.
What defines that very high-risk category that requires a STEMI-like response? What are we looking for?
We're looking for absolute clinical instability. This includes hemodynamic instability or frank cardiogenic shock, recurrent dynamic ECG changes, especially intermittent ST elevation. Ongoing chest pain that is refractory, meaning it doesn't stop, despite aggressive medical treatment, acute severe heart failure, or life-threatening arrhythmias like sustained ventricular tachycardia or ventricular fibrillation. If you see those signs, you rush the patient to the cath lab, no questions asked.
Moving down the risk scale, we find the early ICA recommendation, which means intervention within 24 hours. This is the standard for the high-risk patients we identified with a gray C score.
Correct. And the source material highlights a slight difference in how American and European guidelines approach this. The ESC 2023 guidelines offer a highly structured, almost algorithmic approach. They recommend early ICA within 24 hours for patients who meet those high-risk criteria. A GRACE score greater than 140, dynamic STT changes, or confirmed NSTEMI based on the HSCTN algorithms. This is a Class C recommendation, meaning it's very useful and effective.
And the American approach, the ACAH 2025 guidelines.
They are slightly more flexible. They support early ICA within 24 hours as a reasonable option for high-risk cases, but they place a bit more emphasis on clinician-guided risk assessment rather than dictating strict cutoffs. This flexibility is often driven by regional logistics, available resources, and a focus on cost-effectiveness, though the underlying goal intervening quickly in high-risk individuals remains the same.
Let's discuss the evidence that solidified that 24-hour window. The two landmark randomized controlled trials, or RCTs, were TIMAX and Verdicts.
These trials were essential, but initially a bit confusing. In unselected all-comer NSTE-ACS patients, the large trial showed that an early invasive strategy, with a median time around 14 hours in TIMAX, did not reduce the risk of all-cause mortality compared to a delayed strategy, where the median time was 50 to 61 hours.
That seems counterintuitive, especially after we just said speed is crucial. Why did the general population not see a mortality benefit?
Because NSTEMI is a massive heterogeneous population. Many of the patients in that group who were rushed to the cath lab actually had relatively small, stable coronary lesions or non-type 1 MIs.
Yeah.
For these lower-risk patients, the extra time up to 72 hours allows for effective medical stabilization and doesn't compromise their long-term survival.
So rushing the intermediate risk patient doesn't help them live longer. But what did those trials show for secondary benefits in the general population? Was there any advantage?
Crucially, yes. Both TMAX and Vertice demonstrated a significant reduction in secondary endpoints, specifically a reduction in refractory angina chest pain that keeps coming back and recurrent ischemia. So rushing reduces acute suffering, even if it doesn't shift the mortality needle for everyone.
And this is where the high-risk subgroup analysis becomes the key takeaway from those trials.
Absolutely. When the researchers specifically analyzed the patients who were categorized as high risk, primarily those with a GRACE score above 140, the evidence was unambiguous. In this cohort, the early invasive strategy showed profound benefit. TMAX reported a hazard ratio of 0.65 for the primary endpoint, a huge reduction in death, MI, or stroke.
And Vertice corroborated this.
Yes, Vertice saw a 19% relative risk reduction in composite clinical endpoints at 4.3 years for those high-risk patients. The message is now clinically actionable and extremely clear. For the highest risk and STEMI patients, acting within 24 hours saves lives and reduces long-term events. For everyone else, 24 to 72 hours is generally acceptable, provided they are medically stable.
This evidence naturally leads to a crucial philosophical paradigm shift introduced in the source material. It's moving the primary focus from door to catheter time, the metric we use to judge hospital efficiency, to symptom catheterization, STC time, the total ischemic time the patient endures.
This is a major insight. We spend so much energy optimizing the hospital process, getting the patient from the emergency department door to the cath lab table quickly. But if the patient waited 12 hours at home with chest pain before calling for help, that 2-hour door to catheter time may be, well, irrelevant. The total duration of ischemia is the ultimate determinant of how much heart muscle we can salvage.
Give us the hard data on this. Where's the evidence?
The CAMER NIH registry provided powerful evidence. They analyzed over 5,800 NSTEMI patients and found that patients with an STC delay of less than 48 hours had significantly lower 3-year all-cause mortality. We're talking 7.3% versus 13.4% for those with a longer delay. They also saw lower cardiac mortality and lower rates of rehospitalization for heart failure.
So the patient's own delay in seeking care is arguably the single largest factor compromising their long-term prognosis.
Precisely. The source material pointed out that delayed hospitalization, more than 24 hours after symptom onset, was independently associated with a 1.6-fold increase in mortality. While we have dramatically improved in hospital efficiency, the upstream delay, the patient-related time before they even enter the system, is the new biggest challenge. It requires public health awareness campaigns, better pre-hospital triage, and improved community education.
We've established that high-risk patients are rushed to the invasive coronary angiography suite. But what about the non-high-risk group? The patients with inconclusive or slightly elevated troponins, or those with elevated troponin but completely normal ECGs? We need more information for them.
For this non-high-risk cohort, specialized imaging is advocated. This is where modern non-invasive and invasive imaging tools transform into diagnostic precision instruments. The guidelines give a Class IA recommendation for utilizing advanced imaging to refine the diagnosis when that initial workup is ambiguous.
Let's start with non-invasive imaging. Coronary computed tomography angiography, or CCTA. It's typically used as a rapid rule-out tool in the emergency department.
CCTA is excellent for ruling out obstructive coronary artery disease, or CAD. Because of its superb negative predictive value, it's a Class I recommendation in the ACA guidelines for low-risk patients with suspected ACS whose initial tests are non-diagnostic. By confirming the coronary arteries are clear, it can significantly reduce the necessity for invasive procedures.
Did the clinical trials confirm CCTA's role in actually changing outcomes?
Well, CCTA certainly changes workflow. The RAPID CCCA trial, which looked at intermediate-risk ACS patients with an average GRACE score of 115, found that using early CCTA reduced the hazard for undergoing ICA by 19% compared to standard care. However, for this intermediate risk group, CCTA did not alter the 1-year clinical outcomes like death or subsequent MI.
So CCTA is a phenomenal tool for efficiency and for avoiding unnecessary procedures, but it doesn't necessarily make the patient live longer, at least not in the intermediate risk group.
That's the nuance, exactly. Its success also depends highly on image quality. The anatomical details it reveals, like the presence of high-risk features, such as the napkin ring sign, which suggests inflamed plaque, and critically, the expertise of the reader. It's a powerful gatekeeper, but not necessarily a prognostic powerhouse in itself in that intermediate cohort.
Okay, next we have to tackle one of the most frustrating and challenging diagnoses in cardiology, MINOCA, myocardial infarction with non-obstructive coronary arteries.
MINOCA is defined as a documented MI or myocardial injury in a patient whose angiography shows no obstructive CAD. That means no coronary artery stenosis greater than 50%. It's not a benign condition, and it affects 5 to 14% of all MI patients. Importantly, the source material notes that this condition disproportionately affects females.
So if the angiogram shows no blockage, how do we solve the MINOCA puzzle? Where did the heart attack come from?
We use tissue characterization, and the key tool here is cardiac magnetic resonance, or CMR. CMR is now recommended as a Class I diagnostic tool, especially if a patient with suspected anstema presents before a definitive ICA. Think of it this way. Angiography is a movie of the flowing blood. It shows you the pipes. CMR is a high-resolution photograph of the muscle tissue itself. It shows you the damage.
And how effective is that CMR first strategy?
Highly effective. Studies show that a CMR first approach can completely obviate the need for ICA in about 13% of patients. It is superior in identifying the infarct-related artery, or IRA, even when angiography fails to point it out, which happens in over a third of these cases.
What allows CMR to achieve this level of precision?
The technique of late gadolinium enhancement, or LGE, is the secret. LGE involves administering a contrast agent that accumulates in scarred, necrotic, or damaged tissue. By looking at the pattern of that enhancement, we can tell if the damage is ischemic, a classic heart attack pattern, or if it's non-ischemic.
And that leads to completely different diagnoses.
Precisely. LGE CMR often results in a new, game-changing diagnosis. It might identify a different IRA in 31% of cases, or, crucially, it might provide a non-ischemic diagnosis, things like myocarditis, which is inflammation of the heart muscle, or Takotsubo syndrome, the stress cardiomyopathy, in about 15% of cases. And if the diagnosis shifts to myocarditis, you don't stent, you manage the inflammation. That's a profound change in patient management.
So CMR is the necessary non-invasive step. But what about getting high-resolution images from inside the artery itself? This brings us to intravascular imaging, or IVE, specifically optical coherence tomography, OCT.
And especially OCT is a valuable, albeit class I, tool to identify the true mechanism of the event, particularly when angiography is ambiguous or non-obstructive. Angiography is just a shadow, a 2D silhouette. OCT uses light waves to provide micrometer scale resolution. It lets us see the precise architecture of the plaque and the disruption that caused the event.
And why is that micrometer resolution so important?
Because it allows us to clearly identify the three main types of plaque disruption. The most common is fibrous cap rupture, which is typically associated with the larger, complete blockages of STEMI. But in NST-ACS, we often see plaque erosion, which accounts for 20 to 30% of cases. The third type is the calcified nodule, or CN.
Can you elaborate on the difference between rupture and erosion and why identifying it with OCT is so vital?
Sure. Plaque rupture means the thin fibrous cap covering a lipid-rich pool of cholesterol breaks open, dumping highly thrombogenic material into the bloodstream and causing a massive clot. Plaque erosion means the fibrous cap is intact, but the surface cells have sloughed off, exposing a less lipid-rich but still highly thrombogenic surface. OCT is the only way to discriminate this clearly.
And knowing the difference changes the treatment plan.
Massively. For non-critical stenoses caused specifically by plaque erosion, studies suggest we may actually defer stenting and treat the patient solely with aggressive antiplatelet therapy and statins. This is a revolutionary concept. Imaging guides us to not intervene mechanically. It's a departure from the traditional mentality that if you see a lesion, you must fix it.
OCT also helps identify high-risk features on plaques that haven't ruptured yet. These vulnerable plaques.
Yes. These are often thin cap fibrothromas, or TCFS plaques, with a large lipid core and a very thin, precarious cap. OCT can identify these lesions, even if they aren't causing a flow limitation on angiography.
This raises the possibility of proactive intervention. The PREVENT trial suggested we might start intervening on these vulnerable plaques before they rupture.
That trial showed that prophylactic PCI stenting of non-flow limiting vulnerable plaque so lesions that looked fine functionally but awful on OCT significantly reduced major adverse cardiovascular events compared to just optimal medical therapy. This opens the door to using IVI not just to fix the current problem, but to prevent the next one.
And if IV rules out plaque disruption, we then shift to the non-plaque causes of minoca.
These include issues like epicardial vasospasm, the arteries clamping down due to abnormal contraction, or coronary microvascular dysfunction, CMD, which is a problem with the tiny blood vessels supplying the muscle, and, importantly, spontaneous coronary artery dissection, or SCAD.
SCAD is a critical diagnosis because it often affects younger, otherwise healthy females, and is treated medically, not surgically.
Exactly. SCAD involves a tear in the artery wall that creates an intramural hematoma, a collection of blood within the wall. For certain types of SCAD, like type 2B, which can look deceptively like standard atherosclerosis on angiography, IVI, OCT, or intravascular ultrasound, IVUS, is often necessary to confirm the hematoma and secure the diagnosis.
The ultimate takeaway from this section, according to the sources, is that combining these advanced tools gives us the best shot at solving the mystery.
The Heart-Panuca registry demonstrated this holistic approach. using OCT plus CMR resulted in an identifiable cause of MNOCA in 84.5% of cases. This integrated imaging strategy is crucial for transforming a vague diagnosis into a precise, targeted treatment plan.
Once we've moved past the diagnostic phase and confirmed obstructive coronary artery disease, particularly in high-risk and STEMI patients, we often confront multivessel disease, or MVD. Approximately half of all NSD-ECS patients have MVD.
This is the moment of truth in the cath lab. Do we follow a culprit-only revascularization strategy, meaning we only fix the artery that caused the acute event? Or do we opt for complete revascularization, CR, fixing all significant blockages during that same hospitalization?
The logic for complete revascularization seems sound. If you have other unstable plaques that could cause a future event, why not fix them now?
That's the theory. But the definitive evidence is still, well, lacking in NSTE-ACS. While observational studies and meta-analyses suggest that CR is associated with reduced mortality and MACE compared to culprit-only strategies, we lack large-scale randomized controlled trials focused only on NSTEMI that definitively confirm this benefit. The one relevant RCT, SMILE, only confirmed that performing a single-staged PCI, so doing all the stenting at once, was superior to multi-staged PCI.
So what do clinicians do right now, pending more data?
Current ESC guidelines recommend considering complete revascularization. It's a Class DE recommendation, and ideally this should be done during the index procedure, the same hospital stay, provided the patient is hemodynamically stable. The cardiology world is eagerly anticipating results from ongoing trials like COMPLETE-2 and COMPLETE in STEMI, which should finally provide the definitive comparison we need.
And this brings us back yet again to the inadequacy of angiography for deciding which of those non-culprit lesions actually need fixing.
Angiography, which simply shows the anatomy, the narrowing, is a poor judge of functional severity. A vessel can look 70% blocked on angiography, but if it's not restricting blood flow to the muscle, stenting it won't help and might just increase complication risks. This is why we rely on functional assessment tools like fractional flow reserve, FFR, or instantaneous wave-free ratio, IFR.
How do FFR and IFR work to refine the strategy?
These techniques involve using a pressure wire to measure the pressure difference across a blockage. FFR measures the maximum drop in blood pressure caused by the lesion during induced maximal flow. IFR measures the ratio of pressures during a portion of the cardiac cycle when resistance is naturally lowest. If the FFR is below 0.80 or the IFR is below 0.89, it means the blockage is functionally significant and needs stenting.
This sounds like an essential safety check against unnecessary intervention.
It is. Trials like FAME and FAMOUS in STEMI demonstrated that incorporating FFR refines the revascularization strategy significantly. It helps us avoid intervening on non-flow limiting lesions, which reduces the number of stents used, minimizes patient risk, and reduces the use of contrast dye, which protects the kidneys. The PRIME FFR registry showed FFR-guided management changed the original plan in a striking 38% of cases, often shifting planned stenting to just medical therapy all safely.
But didn't we mention a potential issue with performing functional assessment in the acute setting? A potential caveat?
We did, and it's an important one. In the acute phase of an MI, the heart muscle, the microvasculature, is often inflamed and dysfunctional. This can temporarily make the FFR assessment unreliable or falsely low. Because of this, some experts argue that a delayed assessment, perhaps weeks later, might be more accurate. Due to this ongoing debate about reliability in the acute environment, the ESC currently classifies functional evaluation of non-IRE lesions during the index procedure as a Class I by recommendation. So it may be considered, but it's not yet mandatory.
A major focus of modern guidelines is recognizing that clinical trial data often fails to represent the true diversity of the patient population. This leads to evidence gaps in specific groups. This is particularly true for older adults, patients with prior cardiac surgery, and females.
Let's start with older adults, generally defined as those aged 75 and above. This group is complex because they are often the highest risk but the least likely to receive guideline-directed care.
That phenomenon is called the risk-treatment paradox.
Exactly. This cohort is rapidly increasing, and their presentation is complicated by high rates of comorbidities, increased frailty, and inherently higher bleeding risks from antiplatelet medications. Since they are so underrepresented in the pivotal trials, clinicians are often hesitant to offer the aggressive invasive strategy.
So what does the dedicated evidence show regarding the invasive strategy in this population? Is the mortality benefit we saw in younger, high-risk patients replicated in the elderly?
The evidence is mixed. The After 80 study found that while an invasive strategy reduced subsequent MI and revascularization compared to a selective approach, it had no significant influence on all-cause mortality over the follow-up period.
No influence on mortality. It's a powerful finding tempering the urgency.
It is, and the largest RCT focused on this group, Seniorita, which included over 1,500 patients aged 75 or older, confirmed this trend. The invasive strategy did not result in a significantly lower risk of the composite primary outcome CV death or non-fatal MI over 4.1 years. However, similar to the younger cohort, it did significantly reduce subsequent non-fatal MI and the need for revascularization.
This means the goal shifts, doesn't it? It moves from maximizing overall survival to prioritizing quality of life and preventing subsequent debilitating heart attacks.
Exactly. It mandates personalization. The sources strongly recommend routine, holistic assessment of the older patient's total status, not just their heart. We must use validated tools like the Rockwood or Fried Index for frailty, the Charlson Index for comorbidity burden, and the Montreal Cognitive Assessment, or MoCA, for cognitive impairment. These assessments ensure that the benefits of an invasive procedure truly outweigh the risk of complications, loss of independence, or loss of health-related quality of life.
Moving on to patients with prior KBG coronary artery bypass grafting. They represent about 10% of NSTE-ACS presentations and seem to carry an elevated risk profile.
They are inherently complex. They're older, they have diffuse atherosclerosis, and they face higher procedural risks during ICS, including increased risk of contrast-induced acute kidney injury and stroke. Furthermore, these patients were historically excluded from the pivotal ACS trials, creating a massive clinical evidence void. Registry data confirms they are systematically less likely to undergo angiography or receive PCI.
Given those high procedural risks, does the aggressive invasive strategy still hold up for them?
A dedicated meta-analysis that aggregated outcomes found that a routine invasive strategy in prior CIBG patients did not reduce mortality or MI compared to a selective strategy. This suggests the potential benefits are balanced out by the higher procedural risks associated with manipulating disease bypass grafts.
If the invasive strategy is risky and possibly not beneficial for survival, what is the suggested first diagnostic step for them?
CCTA coronary computed tomography angiography emerges as a potential first-line test. CCTA has excellent sensitivity for assessing bypass graft patency, whether the grafts are open or not. If the CCTA shows patent grafts, clinicians can potentially avoid the higher risks associated with invasive angiography in this fragile group. The BI-PASS CTCA trial supported this, suggesting that CCTA-guided management in this cohort can safely guide care.
Finally, let's discuss females, where historical data shows significant disparities in management and outcomes.
The disparities are long-standing and serious. Females have been severely underrepresented in clinical trials, averaging only about 25% participation. They often present later for medical assessment, perhaps because their symptoms are less classic, and they are consistently less likely to receive guideline-directed care. That includes angiography, revascularization, and subsequent cardiac rehabilitation. This translates to higher in-hospital mortality rates for females in both STEMI and InSTEMI.
And we highlighted earlier that females are disproportionately affected by MNOCA.
Indeed. Females comprise nearly 50% of MNOCA patients, compared to only about 25% of patients who have MI, due to classic obstructive CAD. And even though MNOCA typically carries a better overall prognosis than obstructive MI, female mortality rates remain significantly higher than males across both clinical scenarios.
So given the general debate on timing, what did the specific data show regarding an early versus delayed invasive strategy for high-risk females?
This is a crucial area of recent clarity. While a general meta-analysis showed no overall benefit for early versus delayed timing in the entire female cohort, an individual patient data meta-analysis by Mills and colleagues focused specifically on high-risk females, those with a GRACE score above 140.
And what did they find in that high-risk female group specifically?
They found that high-risk females did experience a significant reduction in the hazard for all-cause mortality and MI at 6 months when they underwent early invasive management. This critical finding underscores the need for dedicated, sex-specific risk stratification, ensuring that high-risk females are not overlooked and are aggressively managed according to the early invasive protocols.
The overarching goal, according to the source material, must be to close this evidence gap, encourage dedicated sex-specific research, and address disparities in care by ensuring personalized, guideline-aligned treatment for all patients, regardless of their demographics.
Shifting gears now to the pharmaceutical foundation of NSTE-ACS care, dual antiplatelet therapy, or DAP. We're talking about aspirin, ASA, plus a potent P2Y12 inhibitor.
That's right. The powerful P2Y12 inhibitors are generally ticagrelor or prasugrel, used to prevent platelets from aggregating and causing further clot formation. DAPT is the default cornerstone therapy, crucial for mitigating thrombotic risks after an acute event.
However, the biggest, most recent paradigm shift discussed in the sources concerns the timing of that P2Y12 inhibitor. It's the debate over P2Y12 pretreatment. Historically, many centers gave this drug immediately upon diagnosis.
Historically, yes, particularly for high-risk patients. The previous rationale was simple: hit the clot hard and fast. But the evidence base has led to a complete reversal of this practice.
What evidence caused this major change in guidelines?
The ACOS trial was a major driver. It showed that routine pretreatment giving the loading dose of a P2Y12 inhibitor like prasugrel before the coronary anatomy was known via angiography increased the rate of major bleeding complications. And it did that without providing a significant improvement in ischemic outcomes. This was especially true for patients who turned out not to need PCI or who needed urgent CABG and had to stop the drug, risking bleeding during surgery.
So the bleeding risk outweighed the potential ischemic benefit in the acute setting when the anatomy was unknown.
Exactly. As a result, the latest ESC guidelines reflect this shift with a Class 3 recommendation, a strong statement against routine pretreatment. It mandates the deferral of P2Y12 inhibitor initiation until coronary anatomy is clearly defined by angiography.
This means we hold the P2Y12 inhibitor until we were standing at the cath lab table, ready to perform PCI. Are there any exceptions at all to this deferral?
Only one. If invasive coronary angiography is anticipated to be significantly delayed, generally defined as beyond 24 hours. In that specific scenario, pretreatment may be considered, a Class II recommendation, to provide some protection against ischemic events while waiting. If the decision is to proceed with PCI without pretreatment, the loading dose is given right at the time of the procedure, with prasugrel generally favored over ticagrelor at that loading dose if the patient is eligible.
And we should also briefly address specialized intravenous options available for intervention.
For patients undergoing PCI who are unable to take oral medication, like those who are intubated or critically ill, the short-acting IV P2Y12 inhibitor, cangrelor, may be considered. Additionally, glycoprotein IVA inhibitors are generally avoided for routine use due to high bleeding risks, but they are critical as bailout therapy. For instance, if there is a massive thrombus burden or an acute no-reflow phenomenon during the PCI procedure.
What about parenteral anticoagulant therapy? That's mandatory alongside DPT.
Absolutely essential. Unfractionated heparin, UFH, is the standard recommended anticoagulant for patients going for immediate or early ICA. Alternatives include enoxaparin. If a delayed angiography is anticipated, fondaparin is actually preferred, but clinicians must remember to administer a UFH bolus if the patient eventually goes for PCI. The review also notes that bivalirudin is another established option that reduces serious bleeding compared to UFH, though outcomes are generally similar.
Let's look at the long-term management now, the duration and de-escalation of DATT. 12 months is the historical default, but personalization is changing this too.
The standard remains 12 months, that's Class 1. But we recognize that the longer a patient is on DAPT, the higher their risk of major bleeding. The goal now, especially for high bleeding risk or HBR patients, is de-escalation. This involves either discontinuing ASA-SO, abbreviated DAPT, or switching the potent P2Y12 inhibitor to a less potent agent like clopidogrel after a short period.
And does the evidence support cutting that 12-month period short?
Robustly. Trials like TICO, MASTER-DAPT, and ULTIMATE-DAPT provided strong evidence that abbreviating DAPT to just 1 to 3 months by discontinuing ASA significantly reduces bleeding complications without compromising the ischemic protection, especially in HBR patients. The ESC gives this abbreviated strategy a Class A recommendation. Furthermore, the Target First trial even suggested that P2Y12 monotherapy after only 1 month might be acceptable for low-risk MI patients who had undergone early complete revascularization.
This is a major shift toward finding the shortest effective duration for maximum safety. What happens after that first year?
After 12 months, standard treatment typically reverts to ASA monotherapy. However, for patients who remain at high ischemic risk, but not high bleeding risk, we may consider prolonged strategies. This includes continuing a reduced dose of ticagrelor plus ASA or adding low-dose rivaroxaban, a direct oral anticoagulant, to the ASA. Interestingly, the host exam trial showed that long-term clopidogrel monotherapy was superior to ASA alone in reducing a composite of thrombotic and bleeding events, presenting a compelling new option for long-term maintenance. Finally, we must address the most complex pharmacological scenario, the need for oral anticoagulation, OAC, often for conditions like atrial fibrillation on top of the ACS regimen. This is a high-wire act. It requires extreme precision to balance ischemic and bleeding risks. The recommendation is to use triple antithrombotic therapy OAC plus ASA plus a P2Y12 inhibitor for the absolute shortest duration possible, typically up to 1 week. The risks are enormous. Following that initial week, the patient should transition quickly to dual therapy, which is OAC plus a P2Y12 inhibitor for up to 12 months.
And which anticoagulants are preferred in this setting?
Direct oral anticoagulants, DOACs, are strongly preferred over the older vitamin K antagonists, VKAs like warfarin. This is due to their superior safety profiles and reduced risk of intracranial hemorrhage in the setting of concomitant antiplatelet therapy. The clinical imperative is always to reduce the intensity of the regimen as quickly and safely as possible.
As we conclude our deep dive, let's look at the major contemporary challenges that clinicians are currently grappling with and where future research will likely focus.
One major philosophical challenge is the emerging interest in reclassifying ACS based on pathophysiology, moving away from the traditional ECG-based definitions.
This is the occlusion MI versus non-occlusion MI, or OMI versus non-OMI paradigm.
Correct. The idea is to classify ACS based on whether there is an acute coronary occlusion OMI or not, non-OMI, trying to align treatment more precisely with the underlying biology and the degree of vessel compromise. While this framework is intellectually promising and might lead to better tailored protocols, the ECG terminology STEM and STEMI is still the immediate dominant factor driving early clinical decisions globally.
Another major challenge is a direct result of the incredible success of high-sensitivity troponins. They're so good, they're causing diagnostic headaches.
Indeed. These assays are now detecting minor myocardial damage very frequently. The challenge is accurately distinguishing between type 1 MI, the classic plaque-related event we focused on, and type 2 MI, which is caused by a supply-demand mismatch.
So type 2 MI is myocardial injury caused by something other than a ruptured plaque, like extreme sepsis, severe anemia, or a very rapid arrhythmia.
Exactly. While type 2 MI still involves heart cell death, the primary treatment isn't a stent. It's addressing the underlying systemic cause, the sepsis, the anemia, the heart rate issue. Since current guidelines heavily focus on treating type 1 MI with antithrombotics and intervention, this growing ambiguity complicates treatment decisions for a significant and increasing number of patients.
And finally, a quick note on the clinical status of unstable angina, or UA.
Thanks to the improved sensitivity of biomarkers, true unstable angina, which is ischemia without any detectable myocardial necrosis or troponin rise, is becoming clinically rare. Most patients who would have previously been labeled UA are now captured under the NSTEMI umbrella due to the detection of minute troponin elevations. This shrinking patient population has led to scrutiny over whether UA needs to maintain its continued separate classification within NSTE-ACS.
It sounds like the entire field is moving toward ever-increasing granularity, requiring clinicians to employ sophisticated tools and personalized approaches for virtually every single patient.
Absolutely. To sum up our deep dive into NSTE-ACS, the management remains highly complex and individualized. The entire roadmap hinges on rapid, precise diagnosis via high-sensitivity cardiac troponin assays and filtered through standardized objective risk stratification using tools like the GRACE score.
And that risk stratification determines the crucial timing. Immediate intervention for the unstable, and early intervention within 24 hours as a life-saving necessity for the high-risk cohort, specifically those with a GRACE score above 140. We also highlighted the increasing importance of advanced imaging, specifically CMR and OCT, for solving the Minooka puzzle and guiding intervention, often leading to decisions to defer stenting in cases of plaque erosion.
And we noted the ongoing evidence gaps in specific high-risk populations, such as older adult and prior CEBG patients, underscoring the necessity of personalized care guided by holistic assessment of frailty and comorbidities.
Yeah.
Pharmacologically, the major takeaway is the strong recommendation to defer P2Y12 inhibitor pretreatment until coronary anatomy is defined, and the widespread adoption of abbreviated DDP strategies to safely mitigate bleeding risk.
So what does this all mean for you, the learner?
Here is our final provocative thought for contemplation, focusing on the evidence around symptom decatheterization time. While hospital staff have successfully shortened the internal door-to-catheter process over the last 2 decades, the evidence suggests that the total symptom decatheterization time, the total ischemic duration, may be the single most crucial, yet hardest to control, factor for improving long-term survival in NSTEMI patients. This suggests that the next great frontier for reducing cardiovascular burden may lie outside the hospital walls, focusing on public health efforts and paramedic triage to minimize the patient's self-delay in seeking help.
A powerful reminder that time is still muscle, regardless of where that time is lost.
Thank you for watching The Funnel Effect.